Excellent. Good evening. Assalamu alaikum, everyone. Uh, Thank you for being here tonight. It's my pleasure to be joined by Dr. Agil Fahad, who's a well-known authority in the upcoming topic that we'll be talking about. Dr. Agil is an intervention, a cardiologist at Mass General and Brigham Hospital, Harvard Medical School. For quite a while now, we've been talking about risk estimation of patients for cardiovascular disease. And it gives us a lot of probably power in deciding which patients to take which treatments. We worked on lots of risk scores that have been advertised by the guidelines. And nevertheless, we can't always predict fully which patients are at higher risk. Uh, 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 the classic risk factors of diabetes, hypertension, and hyperlipidemia, obesity, lack of exercise have all been strong indicators. Nevertheless, we have always talked about family history, about genetic predisposition. So, who are those people who are more predisposed to cardiovascular disease? Interestingly, I came across this year of a World Quality Day celebration, and the theme was Think Differently. With all the push over the years to standardize, to follow checklists, to make sure you're following the rules, there has to be, of course, a wide umbrella that um, and makes sure that we work in a context. But we probably need to differentiate between situations and others, between some people who are at increased risk rather than others, and decide accordingly. Without further ado, I think the topic today is very exciting, polygenic risk scoring for assessing cardiovascular disease or coronary artery disease in patients and people. With this, I would like to welcome again Dr. Fahad, and please, the floor is yours.
Thank you so much, Dr. Habib, for the kind introduction. And truly, it's a pleasure to be able to join you here from Boston this morning, our time, and be able to speak to the audience from the Saudi Heart Association. Um, Again, as Dr. Habib said, the subject of this webinar is going to be really focused on polygenic risk scores for coronary artery disease. And I do realize many have not heard what polygenic risk scores are, and that's completely okay. We're gonna span all the way. This hour will hopefully educate you everything you need to know about this subject as a practicing cardiovascular provider. And I'm just going to mention that I do have a couple of disclosures. As a researcher in the field, I do engage with multiple companies on genetic risk prediction, including some that I founded myself. Um, and the talk will be structured into two parts, and we're going to pause between the two parts to hear more from Dr. Habib about how the Saudi Heart Association is thinking about precision cardiology. But in the first part, we're going to talk about what are polygenic risk scores. So we're going to level set. And then we're going to talk about specifically the clinical utility of polygenic risk scores for prevention of coronary artery disease. And again, this is getting you all up to speed on the science in the past 10, 15 years that makes polygenic risk scores have a clinical utility for coronary artery disease. And then in part two, we're going to talk specifically about optimizing these scores for Arabs, including work done in the kingdom. And then we're going to talk about implementation. How are these being implemented in practice, whether in clinical trials or also being returned to patients today around the world? So let's start with first part. I'm an interventional cardiologist, so I see patients who have heart attack, and I'm pretty sure many of you have seen very similar patients. We know how much early onset coronary heart disease is very prevalent in the kingdom, so I don't need to share with you these stories. You probably see it more than I see it. But this was a 38-year-old man with a healthy lifestyle, just had an annual physical, and then came in the middle of the night with a STEMI, had a crushing chest pain, and had a acute occlusion in the middle right coronary artery. For people who are not seeing this in a cath lab, this is a right coronary artery catheter injecting the artery of the heart, and then there's a blood clot here. And obviously, as we do in a STEMI, we open up this vessel pretty quickly to preserve the heart, prevent sudden cardiac death or heart failure. This is obviously a very young guy with really no risk factors, and I came to round on him the next morning, and he actually asked me, Doc, like I've been doing everything well. I saw my primary care doctor. They told me, I'm doing well. Why did I have a heart attack? And uh, lo and behold, we did go over his checklist of risk factors as per the American Heart Association Life Essential 8. He had no hypertension. His LDL was 131 or 132. Nothing that would, for a 38-year-old, the guidelines wouldn't tell you necessarily to start a statin. His blood sugar was okay. He did not have diabetes. He had a relatively good lifestyle. He exercised, had a normal weight and diet, and did not smoke. And that's quite important. I'm sure you all see these patients, and then we're left wondering. And in reality, a large part of coronary artery disease is actually driven by genetics. The heritability of coronary artery disease is 40 to 60%. So at least half of coronary artery disease is actually driven by genetics. So it wouldn't make sense that we wouldn't measure that. And when we think about genetics or genomic drivers, there's really three major types of genomic drivers of coronary artery disease. The first one is monogenic, and I think this is something that many of us are familiar with. These are rare single defects in our DNA. Most commonly, they're in the LDL receptor gene. So this is familial hypercholesterolemia. People have a single defect. It leads to severely elevated LDL cholesterol. Um, that's rare. That's 1 in 250 people. So not really something that we see pretty commonly. Now, polygenic risk is what we're going to be talking about, which affects most people. And everyone can get a polygenic risk score. And what we'll see is that people will fall on a distribution that looks like a bell-shaped curve, a normal distribution. And a proportion of the population, about 20%, will be at elevated risk. And that's not something that we had been conventionally measuring or looking for. But it does impart a risk that's pretty elevated. And the third part is somatic risk. These are mutations that people accumulate over their lifestyle, leading to clonal hematopoiesis of the indeterminate potential, or CHIP. And we're not going to be talking about this a lot. But in general, when we think about genomic drivers, we think about these three drivers combined. Now, as I mentioned before, you can think about genetics on a spectrum. On the x-axis is allele frequency, how common these are. And then on the y-axis, the magnitude of effect. So monogenic, you have a single defect, very rare, but very strong effect. And when you think about polygenic, you think about variation around people's DNA. Each one of them individually actually has very little effect on risk. Every single variation will increase or decrease risk by 1 or 2%. So it doesn't make sense to use it alone, but only when you combine them together into a polygenic risk score where they start becoming more meaningful. So we think about monogenic LDL receptor effect and elevated LDL cholesterol. We talked about this, and here we're combining them into a score we call a polygenic risk score. We think a lot about polygenic disease when we think about common diseases. So coronary artery disease, atrial fibrillation, obesity, BMI, type 2 diabetes, but also the cancers and inflammatory disorders. And obviously in this talk, we're very focused on coronary artery disease, but there are multiple other applications across these common diseases. Now, let's talk about how we actually calculate it. The starting point for calculating a polygenic risk score are research studies called genome-wide association studies. These are studies that we've been doing for the past 30 years, and they keep increasing in sample size, where we basically compare people with and without a disease. So for coronary artery disease, you take people with coronary disease, people without coronary artery disease. And people will have in their DNA millions of variations from other people. So people have these variations in their DNA, and some of these variations will actually increase risk, shown here in red, and some will decrease risk. So on average, if you look at 100,000 people with disease, 100,000 without disease, you're going to see more red in the people with disease, so more risk increasing variants, and then more green or risk decreasing variants in people without disease. And all the gray are kind of variants that don't increase or decrease risk. They're kind of neutral variants. Now, what we do with polygenic risk scores is we collapse these variants. And again, trying to simplify is a highly computational. There's multiple computational methods here, but for the sake of simplicity, the idea is that we collapse these variants into a single score. And now you bring it at the level of the individual. Basically, for every individual, you're counting the number of these variants, which could be in millions, and the weight of each variant for that individual, and you create a score. And when you plot the score at a population level, as I said before, you'll get normal shaped distribution or bell-shaped curve, where most people will be average risk, and shown in gray. But about 20% of people will be on the far right, you see them in red, or increased risk compared to the average. And about 20% on the left side are actually decreased risk compared to the average. And that's how we express polygenic risk score. It's always compared to a population estimate of risk. Uh, for a single individual, this is what it looks like. We put that distribution, we pinpoint that person on a population distribution. In this case, this person is at the 95th percentile, so that person's risk is significantly elevated compared to the population average. Um, Now, really the paper that kicked off that field was came from our group in 2018 here at Mass General. And really the point it made is that actually the risk that comes from polygenic disease is equivalent to the risk that comes from monogenic disease. So we already have in the guidelines familial hypercholesterolemia. We treat it, we recognize it, we test for it, but it affects 1 in 250 people. What about the other 249 people that we're not testing for? And in fact, you have, again, as I said, about 20% of the population that are actually at the similar increased risk compared to a monogenic variant, and similar increased risk to certain risk factors that we already use and look for, like diabetes, like smoking, like high LDL cholesterol, using genetics alone. And that was kind of the realization that this increased risk level, which is about threefold increased risk or odds ratio of 3, is actually quite important. If you take people specifically with premature heart disease, the signal is even higher. So one way to illustrate it, out of 100 people with a premature MI, you have about um, 2 people that will have a monogenic disease, so about fourfold increased risk. But you're going to have about 20 people that have high polygenic risk. So again, 10 times more people that you're seeing here that are actually having polygenic risk compared to polygenic risk score at the same effect size. So it's a large proportion of the population that you need to be identifying. Uh, the other important thing about genetics is that it identifies people early who otherwise would be flying under the radar. Because this is a risk factor that you can measure in anyone. You don't you don't have to wait until someone is 45 or 50 or 60 until they develop high blood pressure and obesity and diabetes and smoke for a certain number of years. You can theoretically measure this from time of birth in anyone who's young and healthy and know they're predisposed to that high risk. And this is what this is illustrating. These trajectories of risk kind of emerge from earlier in life. And this is using data starting at the age of 40, but this has been shown for younger people. And people might ask, can you pick these people out of the bucket by just measuring other risk factors like LDL cholesterol? And in fact, you cannot. If you take LDL, familial hypercholesterolemia, there's a clear signal. People who have a mutation will have much higher LDL. But if you take people with high PRS versus people without high PRS, there's really not much of a difference. There's a statistically significant difference. But for an individual person, you see the distributions look pretty similar. And it's hard to identify people based on LDL cholesterol. And one might ask, what about pooled cohort equations and clinical risk calculators? And this has been looked at in numerous studies. But the bottom line is that even if you take strata of the pooled cohort equations according to the guidelines, so this is the 10-year ASCVD risk calculator according to the American Heart Association, American College of Cardiology, classified by low, borderline, intermediate, and high on the x-axis. Within each one of these strata, you can actually classify people based on genetic risk. So what that means is that you can actually de-risk certain people in intermediate, and you can up-risk certain people in borderline based on their genetic risk. And when we look at the discrimination of a model that includes genetic risk and pooled cohort equations, the discrimination is similar, which means essentially that just using genetics alone is equivalent to using the pooled cohort equation. But obviously, the best discrimination will be in integrating both. So the current thinking is that you need to integrate both the pooled cohort equations and clinical risk calculators and genetic risk together into a single model. And that would give you the best discrimination of risk for the individual. And again, this is shown from one of the studies that we published back in 2020, but this has been shown in numerous studies since then, and more recently, it's been shown also with the Prevent risk calculator. Age is quite important also. The high-level message here is that genetics is going to be more useful in younger people, which kind of makes sense. If you've waited for someone who's 60 and they already have a lot of risk factors, then genetics is not going to be as predictive because you already have multiple risk factors like diabetes, and they've smoked for a certain amount of years, and metabolic health issues and elevated LDL and hypertension, that those alone are going to be very highly predictive. And genetics, the relative importance of genetics is going to become a little bit lower. But earlier on, the importance of genetics is higher. So these figures are kind of illustrating that. This is a paper that we published earlier this year in Circulation, Genomic, and Precision Medicine. If you look by age strata from 40 to 75, what you're seeing here is that these are the proportion of cases that you are predicting using either clinical, which is with cohort equations in this case, genomic, which is PRS, or both. And what you see that the proportion that you're predicting using genetics is much bigger in younger age groups, and it becomes smaller as you go older. Now, you still have some proportion in the 65 to 70, but it's much smaller. And if you look at the age of actually when an event happened by deciles of the polygenic risk scores or the pooled cohort equation, what you see is that with increasing deciles of the pooled cohort equations, really the age is very much driving that risk calculator. And we know this very well, that clinical risk calculators are very much driven by age. But with genetics, they're not. And the mean age of event is actually, if anything, is actually with the highest polygenic risk score goes down, which tells you that actually genetics is capturing um, events earlier in life, so events in younger people, and it's also capturing events that happen early. So, which means premature coronary artery disease events. And that's very powerful. And this curve on the far right shows you the discrimination, C statistic, by clinical or combination of clinical and genomic. And you'll see that there's an augmentation in prediction, the green line over the blue line, which shows the augmentation of the prediction of the polygenic risk score over a clinical risk calculator, which is present throughout the life course between 40 and 75 years, but it's highest at younger ages. Now, another thing that's actually important is a lot of what I've shown you now is very much focused on primary prevention. I want to say a few words on kind of secondary prevention before we wrap up that first part of the talk. PRS is predictive of subclinical coronary plaque, and that's been shown in multiple studies using coronary CTA. It can predict calcified plaque, it can predict non-calcified plaque, and it can predict high-risk features. Um, but what was more interesting is, and this is a study that we've done with collaborators in Amsterdam AMC, was looking at individuals over time. Does it even predict disease progression over time? And what we found is that actually it's highly strongly predictive of uh, prediction of progression of disease over time. So this was a study that looked at 300 people that had CTAs 10 years apart. So we're able to look at plaque progression over a 10-year interval. And what we've shown is that even if you adjust for baseline plaque prevalence, genetics predicts progression of plaque year on year. So here you're illustrating this with the patient on the left side and the patient on the right side. The left side has high PRS, right side has low PRS. Both have a normal CTA at baseline. But you see that 10 years later, at follow-up, the patient with the high PRS had significant progression of their plaque versus the patient on the right side didn't have plaque at baseline, and 10 years later still didn't have plaque. And now we're able to quantify that. So that starts to tell us that it's not just about predicting disease incidence, it's also predicting worse course of the disease. And this has been replicated in multiple different studies. I'm not going to go in detail. We've looked at this with coronary angiography data. Even when people come into cardiac catheterization, genetics, CAD-PRS remains a very highly predictive tool. It actually predicts people who will have a repeat angiogram, revascularization, and in-stent restenosis, and the 3 to 5-fold increased risk of each one of these events, even after catheterization. This was a large study of 500,000 people looking at the different predictors of recurrent events. So this is among people who have a coronary artery disease event, the risk of a recurrent event. And this is ranked by importance of these risk factors, and genetics CAD-PRS emerges as top risk factor that has the strongest predictive capability for recurrent disease, even when people come in for a first event. So there's a utility not just in primary prevention, but also in secondary prevention. Now, people will say, what would you do about it now that you know you're high risk? But this is genetics. Can you change your genes? What do I tell the patient now that they're high risk? You know, with high LDL cholesterol, I tell them we're going to lower the LDL, et cetera. If they don't exercise, I'll tell them exercise. And this is actually quite important. And our group and others have been for years embarking on research to demonstrate that actually, if you have high genetic risk, you could reduce that risk through different interventions. And the two interventions that I'll highlight is one is lifestyle. And this is a paper that was published in the New England Journal of Medicine in 2016, one of the earliest papers in the polygenic risk score field. And it was published by one of my previous mentors. But basically looked at individuals of high genetic risk. So we're focused on that part of the bar plot on the far right, and said, what if they had a favorable lifestyle versus intermediate lifestyle versus unfavorable lifestyle? And basically what it demonstrated that even if you have a high genetic risk, having a favorable lifestyle can actually cut your risk in half. And it becomes, we're not showing the low genetic risk, but it basically becomes equivalent to not having high genetic risk by just having a favorable lifestyle. So I think this propagated this message that DNA is not destiny. Knowing that you have a high genetic risk is good to know because you can have focused interventions using adopting a healthy lifestyle that actually can reduce your risk to the average of the population. And that's quite important in terms of messaging and counseling patients when we know they have high genetic risk. The other very important intervention is statin initiation and LDL cholesterol lowering. And this was, again, paper that came from our group back in Circulation and looked at, it's a meta-analysis of multiple clinical studies, including clinical trials of statin, and looked at stratification by genetic risk. What it showed is actually if you use PRS enrichment in these trials, which means if you focus the effects of these trials on only people with high genetic risk, what you see that's shown in the red is that the reduction in risk with statin on MACE is actually much higher. So the hazard ratio in the trials of statin is 0.76, but among people with high genetic risk, the hazard ratio is 0.56. And there's both the bars are the difference between the bars is smaller, so the hazard ratio is increased, but also the absolute effects are also higher. So it's an absolute and relative risk decrease with statin therapy among people with high genetic risk, which means they have disproportionate benefit from statins. So if someone has a high genetic risk, it can nudge you to actually start a statin and know that you're going to actually reduce their risk with a statin, even more so than you would reduce the risk of cardiovascular disease in the general population. And that's quite important. I'm not showing this data, but this data has been actually replicated in PCSK9 inhibitors in two trials that followed the Fourier and the Odyssey outcomes trials. As a result of a lot of this data, the HAA in 2022 issued a scientific statement that favored and discussed kind of the risks and pros and cons of polygenic risk scores. I urge you, if you're interested to learn more about the space, to read that scientific statement. It's a little bit outdated. This is 4 years old now. We're in 2026, but it's an important one that discusses the proper use of polygenic risk scores for prevention of cardiovascular disease. And it was the first statement from a American Heart Association. I want to do 2 minutes just before we wrap up this session to just give you some of the latest, a flavor of what's happening some of the work that's in my lab that's either just published or about to be published. Scores keep getting better. This is the original score in 2018 that was published from our group and the more recent score in 2023 that was published. But basically, if you look in blue, the old score and the new score, they keep getting better. In terms of, and this is because improvement in methods and improvement in data sets. The other thing is actually a representation of these scores. Now we see that these scores even get better across different ancestries, and we'll talk about this in the second part of the talk. But methods are leading to improvement in scores. The other thing that's worth talking is my lab has been focused on developing methods that integrate genetic data. So one of the things that we've done is actually developed scores that we can actually use both monogenic and polygenic information in a single risk model. We call this, people who have here in the States, we call it double whammy genetic risk. So you have certain unlucky people who will have a monogenic mutation, but also have a high polygenic risk score. And what happens for these people, if you look at the distribution in black, these are people who have an average risk or non-carriers of a FH mutation, and people who are blue are carriers. But within carriers and non-carriers, you have a stratification of risk by the polygenic risk score. And if you're at the far right here, in that profile, that's the highest risk. And that's the person, like our 38-year-old, who is likely to come in with a premature heart attack. And on the other side, you can have people who are protected despite having a mutation. The risk is actually pretty low because they have a very low polygenic risk score. And that's obviously important for counseling. So we're able to estimate the probability of disease based on that spectrum of risk. We've actually published this paper in 2021 in Nature Communications. We've extended this model to breast cancer, ovarian cancer, and colorectal cancer with Lynch syndrome. And it really stimulated a lot of attention. It was the American Society of Human Genetics dubbed it as one of the main innovations in genomics in 2020. So that was highlighted. A shift of how we think about genetic disease, not just for coronary artery disease here, but across all genetic diseases, no longer thinking about them as only monogenic, but also involving PRSs in evaluating these diseases. And probably I'll impress you more than the American Society of Genetics if I tell you that my name is associated to Angelina Jolie now. A lot of media outlets actually picked up this paper and the work that we've done, and particularly in the context of Angelina Jolie. For people who don't know, she's had a mastectomy based on information of BRCA1 carrier. But then what we've demonstrated in our work that people could have a BRCA1 mutation and actually be protected. So, people are saying, was it not a cancer? Certainly, and she should not have had a mastectomy. So that came up in the context of our work. Uh, and then last but not least, I'll say, some of the work that will be published, it's in press now in Nature Communications from our group, is integrating, as I started the talk, in monogenic, polygenic, and somatic into a single risk model that looks like this, where every single individual, you can put them on a three-dimensional risk map and actually quantify the risk using integration of all DNA information, CAD, PRS, but also monogenic and somatic mutations. And to conclude that part of the talk, I'll say that what I've hopefully have convinced you so far is that the application of CAD polygenic risk score is really present over the life course. At a young age, when we think about young age, thinking 18 to 40, it can help early detection of people at risk prior to the onset of risk factors. These are young people; they have not had a chance because they're so young in accumulating the clinical risk factors. So you can detect that very high risk early. Once you get into middle age, what I call the 40 or young middle age, early middle age, 40 to 55 years, this is where you already have some risk factors, but you can improve the precision in the risk estimation when you add it to the clinical risk calculators. And then in later age, it can be used to guide secondary prevention, as I've shown you with some of the more recent data showing that PRS remains predictive, and that could guide things like intensification of therapy or LDL targets and goals. Um, I want to pause here for this part of the talk and give it back to you, Dr. Walid, and I will resume with the second part of the talk after.
Thank you very much. That was very impressive and thorough, and I personally understood a lot about it right now, looking at that. Allow me to just give a small overview about the Saudi Heart Association. Um, Now, the Saudi Heart Association has been there for more than 35 years, founded on the hands of our seniors and mentors at King Saud University. We're interested to get people together, people in cardiovascular disease, together to share their knowledge and experience and work things together. Um, I was lucky uh, to head the Saudi Heart Association in 2020, but before that, the Saudi Heart Association has worked very hard on introducing many guidelines and position statements that standardize the care according to the evidence available for treatment of many heart diseases. In 2019, we wrote the guidelines on management of heart failure. In 2020, on acute coronary syndrome. We wrote a position statement then on biomarkers for the management of heart failure and acute coronary syndromes. And then chronic coronary syndrome guidelines were published in 2022. In 23, guidelines for the management of hypertension. We updated our heart failure guidelines in 23. And again, we wrote the guidelines on cholesterol and dyslipidemia and many guidelines and position statements thankfully followed that during the last 2 years. And during the COVID era, we wrote many guidelines on management of cardiac disease patients with COVID or who are highly susceptible for COVID. We wrote about cardiovascular disease and diabetes mellitus, obesity and cardiovascular disease. We wrote about the use of NT-proBNP in asymptomatic patients as well, and I think this is one of the risk scoring systems that we have been using, high sensitivity troponins and NT-proBNP on detecting patients with high risk for cardiovascular disease, even if they did not have cardiovascular disease. Now, I think this was a step forward towards personalizing patient care and personalizing cardiovascular disease rather than managing everyone the same. We recently published the vaccination guidelines in adults with cardiovascular disease and how important it is to prevent to prevent disease. And just today, we published the early detection of subclinical atherosclerosis, excuse me, in clinical practice. And I think this is also one way you showed, Dr. Fahad, how the coronary plaques play an important role and their follow-up and the progression. How can these detect and prevent progression into cardiovascular disease? A lot of guidelines and positions are coming through. And I think what I'm trying to reach out here is that as much as we follow the evidence and the studies, and most of the studies are generalized, and we look at, of course, we usually base our p-values and on the outcomes and the absolute value, as you said, and relative risk reduction. Nevertheless, there are those patients who still don't respond the same way, or patients who are at increased risk of cardiovascular disease compared to those with the traditional risk factors. And that opens the door again to how can we be more precise in assessing our patients in risk stratification? How can we really find out who are the patients with cardiovascular disease risk uh, and prevent it from happening as much as possible. With this concept of polygenic risk scoring, this is just to talk about others. I'm going to stop sharing here. With this concept of polygenic risk scoring, we really look forward to have more data and more evidence. And I maybe during the discussion part, we'll discuss more, or we might address it. What has kept it still behind, not making it more in the guidelines or in the risk scoring systems that have been had been published till now? Please, Dr. Fahd.
This is a wonderful, wonderful segue really into the second part of the talk. For a bunch of reasons. I think one is we're going to try to answer that question, right? Like why, and what happens in the guideline. We can talk a little bit in more depth. The other thing that I think we should talk about also in the second part is one, what's the evidence for Arabs? I think a lot of what you've shown us with the guidelines is really about localizing. It's all about how do we localize evidence-based practice of cardiology to Saudi Arabia. And I think really there's no better example on the importance of localization than using genetics, because localizing using genetics is even more important than you're localizing clinical risk calculators and clinical trial data. And I think that's what we'll talk about in the second part. How do we optimize these scores to Arabs? What have been done, and how are they implemented today in practice, and what are the existing barriers and where we see the field moving. So I'm going to start. I painted in the first half a little bit of a great picture, right? Like you would listen to the stock and you're like, God, like I definitely want to get my polygenic score. And I know when I, talk to people, everyone will say, I want to get mine, and it's great. But then you ask the question, like, why don't I see it in the guidelines? Why isn't it not that widespread yet? And I'll highlight what the risks and challenges are. And this is from a 2019 paper by the International Common Disease Alliance Task Force in Nature Medicine. But the first risk that we talk about is a risk from incorrect information. And under that, there's two issues. One is the cross ancestry performance, and that's going to be the one that's very relevant to Saudi Arabia, and we're going to talk about. There is a real issue when these scores are used based on data from Europeans that they underperform in non-European populations. So if you develop a score that's based on genetic data from uh, individuals of European ancestry, it will perform less than individuals of African ancestry. And in Arabs, no one knew until a few years ago, and I'll show you the data. We've done this research and optimized scores for Arabs. The other thing is the calibration. So even beyond just using a score, ancestry and genetic ancestry, it's really around the population that you used. It's like any risk calculator, even the pooled cohort equations, if you take it and apply it in different populations, and actually it's not well calibrated for some populations. And for some population, we don't even know. Like if we studied, for example, the pooled cohort equations performance in specific segments of the population in Saudi Arabia, where maybe it's not well calibrated. So risks of incorrect information. So you give people a risk information, but maybe it wasn't that accurate. There's the other thing is risks from correct information. How do people handle genetic data? I tell you that you're high risk, but maybe there's a risk in telling you you're high risk. I want to make sure it's paired with the right interventions. I want to make sure it's culturally appropriate with genetic counseling and intervention that you can do. You're going to change your lifestyle. You're going to actually start a statin treatment and lower your LDL cholesterol, etc. And then the third one is really around gaps in translation, and that's gets into why we don't see it at scale. You still need this to be widely available as a test, and you want to make sure it's available in a standardized way. It's reported in the right way for people, and then you need enough proof of clinical utility to get the guidelines going. And this is the part I think that we've made a lot of move on. And then there's regulation, and regulation comes into how this test is regulated in a certain country, but also how it's paid for, because payment follows a lot of regulation. And I would say in the US, there's definitely, proof of clinical utility have really reached that stage, and that's pushed the AHA to put a scientific statement. The primary prevention guidelines in the US are going to come shortly. Uh, we don't know for sure, but we think there might be actually a mention of polygenic risk scores in these guidelines that are coming, the new primary prevention guidelines. You have to keep in mind that guidelines always fall behind. We're still practicing based on 2019 guidelines, but we're in 2026 today. And then regulation is also moving along. In the US, polygenic scores are provided as lab developed tests, and large institutions are already developing their tests and actually using it, returning it to patients. And certain payers are already starting to reimburse for that test. And we'll give some examples in this part of the talk. But let's talk about the Eurocentric bias. This is the key paper that talked about this issue for polygenic risk score. This is old, mind you, this is from 2019. Basically, what it's showing on the left side is that most of the genetic data is coming from European, even though Europeans constitute a very small proportion of the population of this world. And that leads to reduction in performance as you go on the left from left side from orange to purple. And the lowest is in individuals of African ancestry. Now, I have to say, a lot of this has been fixed since then by accumulating, particularly for coronary disease, by accumulating more data and improvement in methods. But I want to highlight the work on Arabs. My lab has been focused actually on doing some of that work for Arabs. And we've actually highlighted that Arabs are even way more massively underrepresented. I mean, they're so massively underrepresented that they were not even mentioned in this previous paper in Nature Medicine. So we looked at how much what happened. 1 in 600 data sets in the world, or GWAS participants, these are genetic study participants in the world, are actually Arab, even though Arabs constitute 5% of the world's population. So massive, massive underrepresentation. And really, up until few years ago, the Qatar Biobank was the only really significant nudge that you see here in availability of data for Arabs. But now we're seeing, obviously, with the Saudi genome, with the Emirati genome, we're seeing emergence of new data sets, particularly in the last year or year and a half. This representation, we break it down by country. I urge you to look at that paper if you're interested in go deeper in that space. But again, the biggest bulk we've seen was in Qatar, and then followed by other countries, including Saudi and UAE. What we've confirmed that actually, even if you take plain old polygenic risk scores that are derived in European and are being used in the US and the UK, they will underperform in Arabs, as you would expect, because they're not designed and optimized for Arabs. And the long story short is I'll tell you that we partnered with collaborators in Saudi Arabia, and this work goes back to 2023, and published this paper in Nature Communications, where we actually took 10 cardiometabolic diseases, including coronary disease, and developed new scores particularly optimized for Arabs. And I'm going to say that the population, this was 6,000 people of indigenous Arabs from different tribal representation across the Kingdom of Saudi Arabia. So this was less inbred population and more homogeneous genetic ancestry of Arabs from Saudi Arabia. This work took a lot of attention. The scores were made public, and actually companies started developing these scores that are optimized for Arabs. And since then, we've maintained that level of work, and actually we've been continuing to optimize scores that are approved for Arabs. And what our target is always going to be, we want these scores to perform at least as good as a score in the US would perform for European ancestry patient. And that's what we've been able to achieve for most of these scores today in Arabs. I want to highlight that this work was done in and really enabled with close partnership with Dr. Fuzan Al-Quraya, who's a very prominent Saudi geneticist that many of you might know, and has been a dear friend in that collaboration. Um, this work has led to what we're starting to see in the past year, adoption in the Arab world. The Abu Dhabi Department of Health late last year, actually put guidelines on the use of polygenic risk scores, which I thought was a great step forward. And there are ongoing plans to start to return polygenic risk score at scale in the population of the United Arab Emirates. Um, this is going back a few years. We at Mass General Hospital have actually built a model even back in 2020 of how would we actually return polygenic risk scores to people. So that was one of the first models before any company had actually run that return polygenic risk scores to people of actually devising report. So this is what one of the first reports of polygenic risk scores looked like. It's a report that we optimized over a year and a half to ensure that people can understand it and it's actionable. So you've already seen in my slides a lot of the visuals from that report. This is what it looks like. We put out a website called polygenicscores.org that provides education about the use of polygenic risk scores. And then we launched a clinic called the Preventive Genomics Clinic here at Mass General, where we actually return polygenic and monogenic information to people. And in that clinic, this was self-referral plus referral from primary care doctors and cardiologists. We found that about 25% had high genomic risk, 20% had high polygenic risk, and 5% had this kind of combined monogenic polygenic risk, what I talked about as the double whammy risk. These are people at extremely high risk. And then we tracked what happened. What did actually people do when they learned about their high genetic risk, and what did doctors do? And what we found is that about half of them had a change in clinical management. And most of that revolved around statin initiation or statin intensification, or obtaining coronary artery imaging, such as calcium score or coronary CTA, to look for subclinical plaque. And again, this provided one of the first implementation frameworks for polygenic risk scores. Since then, there's a lot of companies that have adopted this model and actually taken it to scale across different institutions in the United States and the United Kingdom. An area that I'm not going to go a lot in, but I want to highlight that polygenic risk scores can also be used to improve the efficiency and reduce the cost of clinical trials, particularly in cardiovascular disease, where the cost of outcomes trials is in the hundreds of millions of dollars to achieve and take up to 7 years to actually achieve, which really is putting a barrier on drug development. This was a paper that we put in Nature Communications in 2022, illustrating that concept and showing that we can massively improve the power of the trial by reducing the sample size. This is a PCSK9 inhibitor trial where the sample of size goes from 25,000 to 3,000 on the right side, just by using polygenic score enrichment in these clinical trials. And it's something that a lot of companies are interested in, are exploring actively. This was the paper, and what I want to leave you on is the journey that we've taken since that paper in 2022. We've actually went on to launch the first clinical trial that uses polygenic risk scores to enrich for drug treatment. And this is a trial called PROACT. It is NIH funded, and I get the honor of leading that trial here at Mass General Hospital. And the trial is expected to have a final readout in 2027, but it was first presented at the last American Heart Association. And there's a paper that's incoming in the coming few weeks in JACC about the trial, and I'll share some of the data about that here. But in this trial, it's a proof of concept trial. It's 400 people, exactly everyone I've been telling you about. These are people 40 to 75 who have a high genetic risk, they have a high CAD PRS, but have no known cardiovascular disease, and they're actually low clinical risk. They're not on lipid-lowering meds. These are literally the people that you see in your clinic and you say you're good. You don't have, if you didn't know about their coronary disease polygenic risk score, you would call them low risk. And we are inviting all these people, and we are obtaining a coronary CTA on every single one of them. And we're collecting biomarkers, and we're evaluating the cardiovascular health and following them over time. Now, for people who do have plaque, we are actually designing a trial. We designed a trial where we look at plaque change over time with statin and low-dose colchicine, and this trial will read in 2027. These are for people with plaque. The people without plaque, we are testing an intervention of disclosure versus no disclosure on change in life's essential 8. And again, this trial will also read in 2027. But what we've learned this year, and this is looking at the first 204 participants in this trial, is that plaque prevalence is extremely, extremely high in people with high genetic risk that are flying under the radar. So we confirm prospectively in pretty dramatic way how high it is. Basically, in this trial, 70% were women, 76% of males had plaque, and 40% of females had plaque. Extremely high prevalence of plaque in people who otherwise are low clinical risk. Uh, the mean pooled cohort equations risk, 10-year risk was about 3% in this trial. And most people were actually lower borderline risk in this trial based on clinical risk calculators. So they wouldn't have gotten a statin before this trial. And obviously they would need a statin given the high prevalence of plaque here. Another thing worth noting is plaque is prevalent even in younger age groups. You look at men age 40 to 49. These are men under the age of 50, and plaque prevalence is 55%. Even in women, as women 50 postmenopausal 50 to 59, you're seeing a plaque prevalence of 30%. And this trial, mind you, is in Boston, where overall healthy lifestyle is pretty good. People have pretty healthy lifestyle, exercise, and fit. So this is exclusively driven by, predominantly driven by the high genetic risk. And I want to leave you with this with this slide from that trial. This is one of the participants of the trial. This is a 46-year-old man who had no clinical risk factors. He had a PCE 10-year ACV risk of 2.3%. He had a CAD PRS that was 98th percentile. He had a CAC score of 0. So by all measures in the existing guidelines, he would not get a statin. And when we did the coronary CTA, he had a non-calcified middle-AD plaque. And this is not a zebra. Most of the patients in the trial look like this patient, where they're low clinical risk and otherwise wouldn't be detected uh, unless you look at genetic risk. So this paper will be out in JACC soon. It is accepted for publication. Uh, I want to leave you with so what I've given you a lot of kind of implementation insights, clinical trial insights, what's coming down the pike, what is happening today, how are people actually getting their polygenic risk score. The reports are kind of emerging from one trait into multiple traits. This is actually the report that at my institution here in Boston, Mass General Brigham, we have. We already are sending this clinically on patients. I can order this in the chart on patients. And here's what I get. I get basically 9 different diseases. And I get for each one of these diseases, I get is a below average, average, above average, and high. And then I can decide what to do with it. So this is the score that we are going with at my institution here in Boston. Um, uh, where are people getting the PRS around the world in the USA? Again, I have I wanted to highlight some of the companies that are actually people are going actually and getting these. Allelica, Myome, and then institutions like MGB are actually testing nationwide. So patients and doctors, it's a physician order test in the US through one of these providers. In the UK, the largest company is Genomics. It used to be called Genomics PLC, and people are getting the PRS through that company. In the UAE, Qatar, and Lebanon, we have a large company called Avicenna. That's actually the main provider of polygenic risk scores in the MENA region. And in the kingdom, it was a pleasure, partnering with Novo Genomics, which is the provider of this score in the kingdom today. And this is from a picture when we signed the MOU with the Vice Minister of Health in the kingdom overseeing this MOU signed with Novo Genomics. I want to wrap up here by saying that a lot of the work, most of the work that I presented is really a labor of love from my research lab here in Boston. I have about 20 people in my lab, all the way from postdocs, junior faculty to medical students and undergraduate students who really make all this work possible. This is a picture from one of our last social activities in the lab. And then I've had also a chance to partner with colleagues in my institution and outside my institution, including some in Saudi Arabia, which has been a pleasure and really enabled that work. And maybe with this, we'll wrap it up. And I know we have about 10 minutes left for questions and discussion.
Thank you very much. Very impressive, and I hope it sees the light more with more potential in helping our patients. Let me ask you now, clinically or practically, who would you recommend in your patients to have such a test?
Yeah, right. This is a great point, right? Like I think anyone in general, patients who this is at the end of the day, it's a shared decision making. So patients need to be wanting to learn about hidden genetic risk and be wanting to make changes. So what we're saying is early adopters are coming from either patients who had an event and they're trying to explain what happened, like the patient that I started with. So early premature coronary disease that I just like, I feel like, why did I have an event? I really want to know. And then if I know, I'm going to be very aggressive and even more intensive about treating that. Now, some might argue that you need to be intensive no matter what with treatment. But what we're showing with the data that you can even be more intensive. I actually, on these patients, when I know they have high genetic risk, I lower LDL as low as possible. I know the guidelines will say under 55. I go under 40. I go all in on lowering LDL. There is no reason to be cute. I know the lower, the better, the longer. I'm going to lower it as much as possible. So that's in the secondary prevention world. I take all my guns out and I lower the risk as much as I can. In the primary prevention route, I think a lot about young people with the same way I measure LDL cholesterol and I measure A1C and I measure LPA, I measure CAD PRS on everyone who's young and want to know about the risk. Because if I didn't, I'm leaving 30 to 40% of the risk that's explained actually unmeasured and hidden and wouldn't know about it. And so I measure it in everyone. And if someone has a high polygenic risk score and an LDL of that sub threshold for primary prevention, it nudges me to start a statin on them. I wouldn't be comfortable personally with an LDL of 130 with high polygenic risk because the data shows very clearly that this person is going to be a threefold increased risk, which is equivalent to having an LDL of 180.
Yeah. I would probably add those with strong family history of premature coronary artery disease or cardiovascular disease, um, just to certain if they carry the same risk or not. How's the coverage in the States? Is it covered by insurance? Is it paid for?
Yeah, so not by the way, great point on the family history, and I have to say the family history we didn't talk a lot about it. There's complementary information, so people sometimes ask if family history, could I just use family history? No, even within the knowledge of family history, genetics can augment that. So there's complementary information that you get with genetics. But the interesting thing about family history, as you said, people are actually more willing to adopt genetic testing when they have a family history for obvious reasons. With regards to coverage in the US, it's not high. It is not covered routinely by most insurance, so it does end up to be out of pocket for many people. It is a battle of companies now negotiating with payers to get it covered, and there are different pathways to get it covered through payers through some of the companies. Specifically at my institution, for example, at Mass General Brigham, it is not covered for most people. It costs a few $100s, and people pay it out of pocket.
I think it's worth it, and hopefully once it makes it more into the guidelines and recommendations, we can get payers to cover it. Now, could it work on in the opposite way, meaning that if I have low polygenic score, I would relax on my lifestyle and my
Yeah.
food habits and medications. Could that be an issue as well?
It's a great question, and it's really a hard thing to do, right? You're asking the hard question because you know it's hard. It's always hard to de-risk people, right? Because it always goes, how certain are you to risk? It's much easier to up-risk people and start an intervention. And that's kind of how we practice in medicine. Now, what I want to say, though, so a lot of the messaging on implementation is not focused on de-risking, is focused on up-risking from an implementation perspective. Now, what I want to say is the right model is not using it as yet another measure to de-risk people. The right model is using what we call integrated risk calculators, which means I take on BCE or prevent or whatever clinical risk factors you have. I take on knowledge of your monogenic disease. I take on knowledge of polygenic risk score, and I get you a single estimate. And if you do it that way, then it kind of doesn't matter anymore for up-risking. You're naturally de-risking and up-risking anyways, because now you're calculating your single lifetime risk measure that you can update over time and say, okay, well, what am I comfortable with? If that threshold maybe exceeds 5% or 10%, then I kind of want to start a statin. And that's kind of how we think about it. So, and some companies are already doing that. One of the companies I put in my slides, that's all they do. They do what we call it integrated. That's how they see the world. They call it integrated risk scores. So they only want to do integrated so they only provide a single estimate. You will have to plug in your pooled cohort equation, essentially risk factors, and actually calculate a single estimate, which is essentially a pooled cohort equation estimate adjusted for genetics and recalibrated. And I think that's going to be the main model to go because otherwise people could get confused by discordant information. I have a low lipoprotein A. I don't smoke and I have all these healthy stuff, but I have high genetics. It could get very confusing. How do I put them all together?
Nice. There was a question that came in here. would it direct you as an interventionist to decide between revascularization or medical therapy in any way?
Not yet, not yet. I mean, that would be right, like a dream. I think if we can get there, we don't have any data to suggest that at this stage. What would be interesting is to understand. So you've seen some of the work in genetics with people who have cardiac catheterization, and what we this is based on a data set of about 6,000 people that we have in our institution who have genetics and have cardiac catheterization follow up over time to understand what happened. But we don't have the resolution to understand, is it driven mostly by just plaque burden accumulation, or is it driven by actually vulnerability of plaque rupture and erosion? There's a recent paper that came a few weeks ago based on autopsy studies having some suggestion on plaque erosion versus rupture, but the field is so early and we don't have the right data to have that indication. What we know for sure is that polygenic score definitely increases burden and plaque accumulation over time. I don't know how much uh, yet that actually could predict actual plaque rupture and plaque. I don't think we have enough data to suggest that. So we have ways to go still in that direction.
Excellent. I liked it when you pointed out how the role could be in clinical trials and how it could reduce the cost. And I hope many more companies actually adopt to this and use it for risk stratification and choosing the right patients. In trials and in practice, it would be a very good model for the future. Um, with this, I would really like to thank you for being with us today, for giving this very excellent overview of understanding the concept of polygenic scores, the practice and the practicality of it, how we look forward to it. And I hope it gets adopted soon and becomes part of the standard practice. Again, thank you very much for being here. I thank everyone for attending and for their support and look forward for future collaboration and work. Thank you.
Thank you so much. Thank you. Pleasure giving this talk, and I appreciate the invitation.
Thank you very much. Have a good day and rest of the day and good evening for everyone else. Thank you.